We can go to the next slide where we will start with our agenda. Today, Paula Shoup, one of our epidemiologists with the viral hepatitis program at TDH, will be sharing about hepatitis C surveillance and some reporting information in our state as well. I want to give everyone just a moment to go to this link or use the QR code to make sure that you have also registered for Southeast AETC. If you are interested in continuing educations, this will be the way to get those. And thank you, Kimber. She just dropped it in the chat for everyone, so you can click that link. So we'll give it just a moment to make sure that you have registered for today's session as well. And for those that have registered in the past, you should just be able to go to your dashboard and it'll show the event, or rather the calendar, and add the event. It's very quick. For those that have not, it'll take you just a moment to fill out a profile. But thank you so much for doing that. So next we'll get started with some introductions. If you don't mind, please introduce yourself in the chat. We will have you add your name, your role, what organization you're with, and whether or not this is your first ECHO session. I am seeing some names that I recognize, so thank you so much for joining us again, as well as some names that I recognize, but I'm not sure if they joined an ECHO with us before, so welcome. We're really excited to have you with us this afternoon. I see chats going in. Awesome. Welcome, everyone. So we will get started now on our presentation. As I said, we have a guest speaker this afternoon, Paula. She is one of our epidemiologists and epidemiologists too, and our core surveillance epidemiologist with the Department of Health. So she's going to give some overview on some recent trends and information, and then we shall go from there. Paula, I will pass it to you.
Thanks, Mia. Hi, everyone. My name is Paula Shoup, and I'm an epidemiologist in the viral hepatitis program at TDH, and I'm going to be sharing a bit about our surveillance projects and reporting. Next slide. So I'll share a bit about our actual duties in surveillance, and then I'll cover some national and local Hep C trends, as well as a bit about cancer and death with Hep C and some of our ongoing projects. Next slide. Next slide. So this is our actual surveillance team. We have 5 epidemiologists and 5 data entry team members. Next slide. And within our Hep C surveillance duties, we process all the labs we receive for the state, which is over 600,000 labs annually. With those labs, we create investigations, we identify acute cases, we make sure that proper case classification is applied, we investigate any acute cases, any case that we suspected of being acquired through as an HAI, any cases identified at a dialysis center, and the EPIs serve as data managers for our viral hepatitis nurse navigator REDCap projects. We monitor our reportable labs to make sure we're receiving everything that we should be. We analyze case trends, and each year we produce an EPI profile. Next slide. There's a number of conditions that are reportable for Hep C, both for CDC and Tennessee. That includes acute and chronic Hep C and perinatal Hep C. We also track a number of local conditions that we don't send on to CDC, and that includes positive pregnant female and hepatitis C reinfection or treatment failure. For labs, only positive HCV antibodies and positive and negative Hep C RNAs, as well as negative Hep C antibodies for persons aged 0 to 36 months are reportable to the state, and these are generally commercial labs that are sending us these results. If anybody does have a positive Hep C lab, the laboratory is supposed to let us know the person's pregnancy status and any other virological markers that the person has, as well as the liver enzymes for the individual. For individual providers, they only need to report acute hepatitis C to the state. And this is through a PH 1600 form. And I'll drop a link in the chat afterwards for our reportable conditions webpage. Next slide. Our last case definition update for Hep C was in 2020. Essentially, anybody who has a positive antibody is a chronic probable case. An RNA positive is a chronic confirmed case, and anybody who's RNA negative is not considered a case at all. For looking for acute cases, we look for anybody who is jaundiced, has a total bilirubin greater than 3, or an ALT greater than 200. We also look for seroconversion, so anybody with a negative antibody who becomes positive antibody or positive RNA within a year, as well as test conversions, so anybody that's RNA negative to RNA positive within a year. Next slide. We do regular quality assurance in all our investigations using SAS code. We make sure that proper case definition was applied, that all cases have a notification going to CDC. If there's multiple positive labs on a panel, we make sure all investigations were created. We look for duplicate records, and we merge any patients that have multiple records in our surveillance system. And we also make sure that we don't have any missed acute cases. Next slide. We use a number of outside data sources to look at our quality of our investigations as well. One of the main ones is our quality assurance report from CDC, which we receive each quarter. And they look at our race, ethnicity, sex, county, any risk factors for our acute cases. There are certain metrics that we have to meet for our grant for CDC. So they report back that data to us, and they also share national trends. In this panel, we have Hep A, Hep B, and acute Hep C. And in the right-hand side for acute hepatitis C, you can see that cases are downtrending from 2021 forward. So we would expect a similar trend here in Tennessee. Next slide. We also use the National Notifiable Disease Surveillance System. This is also maintained by CDC, and this allows us to look at like the general breakdown of our acute hepatitis C demographics. So you can see in the pie charts on the left-hand side, the majority of our acute hepatitis C cases are male, and they have received the bottom pie chart. Most of them have received their confirmatory testing. When we look at age group, most of them are between the age of 30 to 39, and they're white, non-Hispanic. CDC also provides us with an epi curve, and you can see the curve on the bottom towards the end around December 2023. We have a peak in cases, so that alerts us there's something unusual we should look at. When we looked at our chronic cases as well for that time frame, we saw a similar peak. When we looked at our data further, we realized that that data was being driven by overdoses, which prompted us to work with the group that maintains opioid and overdose data to drill down on that data further. Next slide. We also use the Decipher surveillance system, which is another system that CDC maintains, and it includes hospitalizations, death data, as well as some more national trends. And this chart is our case rates in pink compared to the national rates on the bottom in blue, black. And you can see we're much higher than the national trends, but we are trending downward, similar to the national rates. Next slide. And next, I'll cover some national and local trends. Next slide. Before we look at our maps for our Hep C trends, I wanted to share very quickly the vulnerability assessment that was done by CDC in 2015 in response to the HIV/HCV outbreak in Scott County, Indiana. CDC did a really nice analysis looking at the most vulnerable counties in the United States to see who was most at risk for having a similar outbreak. Next slide. And 41 of the 220 most high-risk counties were found in Tennessee. If you look at this distribution of the most vulnerable counties in South Central region, Upper Cumberland, East and Northeast, kind of keep that in mind as we look at our maps, because this trend persists even almost 10 years later. Next slide. And here I have a map of the national acute hepatitis C rates for our country, and CDC produced this last year, and this is the most recent data that they have for acute hepatitis C. And you can see the highest rates are in that navy blue, and we're in that highest rate category. Next slide. When we drill down further and we look at our data to see our case rates here in Tennessee, you can see very similar to the vulnerability index. Our highest rates are in South Central region, in Northern Upper Cumberland region, East and Northeast. Next slide. When we look at our counts and rates for acute C from 2016 to 2023, we see a peak in 2019 and sorry. We see a peak in 2019, and that was driven by a Hep A outbreak. And then in 2020, of course, with COVID, we had a decrease in cases. And then from 2022 to 2023, we see another big spike in cases. And that was due to more complete reporting from the state prison system, as well as another large hospital system in the state. Next slide. When we look at our breakdown for probable and confirmed acute C in the state, in gray are people who only have had an antibody, and in blue are people who have received their confirmatory RNA testing. We see from 2019, a lot more of our cases are getting their RNA confirmatory testing, which is really positive. And we had around 500 acute HCV cases last year. Next slide. When we look at race and ethnicity for our acute cases, our highest group is in that light blue, and that's in our other non-Hispanic race group. So anybody who's Asian, American Indian, multiracial, that is the highest group increasing over time. We're also increasing for white and Hispanic and holding steady for Black. Next slide. When we look at sex and age, in the dark blue lines, most of our acute Hep C is amongst males in their late 30s to around 50. Next slide. For risk factors, if you look at the gray line for incarceration, we see a big increase from 2022 to last year, and that's again driven by more complete data from the state prison system. Interestingly, in the red line for IV drug use, we're kind of trending down, and then for IV drug use, we're trending down, which is contrary to national trends, which has non-IV drug use increasing. So we're keeping an eye on that as well. Next slide. Next, we're going to cover our chronic hepatitis C, and here we have our case rates for the entire state. You see the entire state is impacted by chronic Hep C, and we see a similar distribution for our vulnerability index with South Central region, Northern Upper Cumberland, East and Northeast having the highest case rates. Next slide. Unlike acute hepatitis C, we've been downtrending since 2021 for these cases. A number of different factors occurred in 2020. In addition to COVID, of course, we had a case definition change, and we also had a big increase in overdose deaths. So and all those factors working together, we think are impacting the change in our counts and rates for our chronic hepatitis C, but we've been averaging around 7,000 cases a year. Next slide. When we look at the distribution between probable and confirmed, again, probable is people with just an antibody. Confirmed in blue are people that have their RNA testing. Most of our confirmed cases are getting their RNA test. Next slide. When we look at race and ethnicity, we see different trends than for acute C. Non-Hispanic other is decreasing, and we're holding steady for white, Black, and Hispanic. Next slide. And I'm going to flip between this slide and the next one. Can you go to the next one? I wanted to share this distribution first for chronic Hep C by sex and age, which was produced by CDC last year. So we see that typical double hump of millennials, Gen X, for the first larger new cases. And then we see our smaller second hump for our baby boomer population. And if we flip back to ours for Tennessee, You see, our first hump is much larger. So our millennials and Gen X are driving our new cases, and our second hump with our baby boomers is much smaller. Next slide. Next slide. And here I have a distribution of our case rates for perinatal Hep C, and you can see that this map is almost an exact replica of the most vulnerable counties for the vulnerability index, especially in Upper Cumberland and East. That's where we see the majority of these exposures. So from infancy all the way to chronic cases, these particular counties have the highest rates of hepatitis C in the state. Next slide. We also produce a clearance cascade for hepatitis C every year. So we essentially look at everybody who's tested and we look at their long-term outcomes. Next slide. So for this first column, ever infected, this is anybody who's had viral hepatitis testing. And then in our second column for viral hep testing is anybody who's had confirmatory tests, RNA positive or negative. That initial infection are people that we know have an RNA positive. And then our cured or cleared are anybody who's gone on to have an RNA negative after their RNA positive. So around 40% of cases going on to cure or clear. And then that last column is essentially our reinfection category. And most of those cases are found in the state prison system. Next slide. We've also been looking at an incidence for our people living with HCV in the state. So anybody who the state has received a lab from 2000 to 2022, we assess their labs to look at active infections for the state. So there's anybody with an antibody positive and no RNA testing, or people whose last test was RNA positive who are living in the state and not known to be deceased. So as of our last count, we think around 114,000 people are living with Hep C in the state. And we have our map below with the actual distribution of where our patient population is living. And again, pretty much the entire state is impacted, with Upper Cumberland and East having the bulk of the cases. Next slide. When we look at our distribution of sex and age, we see that more typical double hump with our millennials, Gen X having the highest number of cases, followed by our baby boomers in the 55 to 64 category. Next slide. Next, I'll cover a bit about cancer and death for Hep C. Next slide. This is all of our cancer diagnoses that we know of from 2000 to 2022. What I think is interesting about this chart is from around 2015 to present, we're seeing what looks like a decrease in new cancer diagnoses. Of course, with 2020, sure, COVID had an impact in the number of people who are receiving a cancer diagnosis, but it does look like we are seeing a genuine decrease, hopefully related to treatment. Next slide. When we look at that age group for when somebody is diagnosed with cancer, it's usually between the age of 50 to 59, followed by 60 to 69. Next slide. When we look at the specific kind of cancer diagnoses that people are receiving, the majority are in the digestive organ ICD-10 group, which when we looked at that further, the majority of those were liver cancer, and then followed by lung cancer, prostate cancer, and breast cancer. Next slide. Next, I'll cover a bit about death rates. This is another map produced by CDC last year. The dark category is the highest rates for the highest death rates, and they looked at anybody who had a Hep C ICD-10 code on their death certificate to come up with this case rate. So not only do we have some of the highest rates of new acute cases, but we also have the poorer outcomes of people actually dying from their Hep C. Next slide. When we look at our local death certificates, we do see a slight increase or a slight decrease from 2021 to 2022. So we do appear to be trending downward as far as people living in the state who have hepatitis C on their death certificate. Next slide. When we look at the actual primary cause of death for people who have Hep C listed anywhere on their death certificate, around 30% of people have viral hepatitis actually attributed to this is what caused this person to die, followed by cancer, chronic liver disease and cirrhosis, heart disease, and substance use disorder or accidental overdose. I included Hep B as a point of comparison. For people that are co-infected with B and C, they have a higher rate of viral hepatitis, but lower cancer, which I thought was interesting. A slightly higher chronic liver disease and cirrhosis, and for substance use and accidental overdose, it was twice as high. So for individuals living with B and C, this is a more vulnerable group of people. At the bottom, we have the median age of death. For the general population in Tennessee, it's 74. For those who have Hep C, it's 60. And then for B and C co-infection, it's 52. So people living with these viruses do have a lower life expectancy than the general population. Next slide. And then we also included this chart, and this is anybody in our surveillance system that has matched to a death certificate. On the bottom, we have our light blue category, and this is anybody who's died from a liver-related issue, so liver cancer, liver failure, cirrhosis. From 2008 to last year, we see a steady decrease from 25% of cases all the way down to less than 5% of cases are dying from liver failure. So it's super positive, hopefully related to more people getting treatment and clearing their infection and not having those poor long-term outcomes. Unfortunately, on the top, we have our accidental overdoses. And from around 2012 forward, we see a steady increase in the number of people passing away from accidental overdose from around 5% in 2012 to almost a quarter of our patients in 2023 that passed away from overdose. So we have a very vulnerable population that has a pressing need for intervention and harm reduction. Next slide. And last, I'll cover a bit of our ongoing projects that we're working on. Next slide. The first is our mobility project for people living with hepatitis C who have a history of incarceration. Again, I noted a couple of times that we've seen a steady increase in the number of cases in the state prison system. So we are trying to get a handle of how those cases are moving through the prison system and also going back into the community. So the map that we have here are RNA positive individuals who have left the prison system and kind of where they're living after they served their sentence and they're back in the community. So you can see it's primarily east and in our metropolitan areas where we're seeing those cases, but pretty much the entire state is impacted. So we're further drilling down on that data to see where we can be most impactful to do some kind of intervention. Next slide.